tonight we're honored to have someone I'm really excited to hear from, Dr. Thomas Insel. Dr. Insel was the director, he's a psychiatrist, and he was the director of the National Institute of Mental Health for quite a few years. He's recognized as a national leader in mental health research, policy, and technology. And Dr. Insel is a member of the National Academy of Medicine and has received numerous national and international awards, including honorary degrees in the United States and Europe. And Dr. Insel will be giving about a half-an-hour presentation going over his book. This is his book. It's probably backwards. Oh, no, it's not backwards. I'm surprised. But his book is Healing, Our Path from Mental Illness to Mental Health. I can't speak highly enough of this book. I read it about 6 months ago, and it's both very readable and not that long. As I was sharing with Dr. Insel, it doesn't take you, 4 months to get through, and he gives a really good overview of the problems with mental health care in our country, and also addresses some of the solutions and some of the promising aspects of mental health care that we ought to be pursuing. And so I'll turn it over to Dr. Insel. If you have questions, and we do encourage questions, we'll handle those after Dr. Insel's presentation. Feel free to either put them in the chat, or we'd love to hear from you in person, so to speak, or live if you'd like to do that. We don't require people to have their cameras on, but if you feel comfortable having your camera on, we'd love to see who's joining us as well with your camera on. So with that, it's my pleasure to introduce Dr. Thomas Insel, and take it away, Tom.
All right, thanks, Craig. A real pleasure to be here, and actually to celebrate World Mental Health Day with all of you. It's a good day to at least mark the occasion, and it's kind of stunning to me because I think in the past this is one of those kind of hallmark days that comes and goes and nobody pays much attention, but it's getting a huge amount of attention right now. I know it's in because I got a note about an hour ago from my grandson's Little League team that this was World Mental Health Day, which is kind of pretty far-fetched. I would never expected the awareness to go that far. It's probably because right now we're finding ourselves not only watching a number of wars take off around the world, but also in a kind of global mental health crisis. And particularly in the United States, there's this sense that we're really in a crisis. And this is, in some ways, was true before COVID, but I think even more so since. And I guess for me, the real question is how we got into this mess and how do we get out of it? So as Craig said, I've written this book. Let me bring up my slides and you'll actually see what I was going to talk about. Here we go. You able to see these okay? Yeah. Okay. The book is Healing. Craig had just put it up there. And the reason I wrote it was having been kind of at the wheel of mental health research and to some extent mental health policy throughout the Bush and Obama administrations, and seeing just enormous progress in science, I was just stunned by the lack of progress in outcomes. And this book really was an attempt to try to figure this out. So it didn't make any sense to me that we couldn't do better when the science had gone so far. We had good treatments to offer. We're spending more and more on mental health issues. And yet here we are in what the White House, the Congress, the Surgeon General, and 90% of Americans feel is a crisis in mental health. So what I wanted to talk to you about is kind of how we got there. It's actually not a single crisis. There are really three different parts of it that I think we should talk about separately. There's a youth mental health crisis, which is really national and seems to affect young women more than young men. Okay, can you hear me now? Good. Uh, so the issue here is around trying to understand uh, why so many kids are struggling so much in this post-COVID era, some of which we think is driven by social media. There are a lot of factors. SMI is, as you know, serious mental illness, very different set of problems, different drivers, different solutions, but really a crisis that's not so much about many, many more people affected. It's more about our failure to provide the care that many people need. SUD, substance use disorder, um, and that part of the crisis, most of all, is driven by the, uh, the the use of fentanyl. So we now have drugs that are far more lethal. As somebody said to me recently, the era of recreational drug use is over, because even the first use of an opiate laced with fentanyl can be fatal. Uh, as it says here, this is a particularly interesting time. We had um, a number of policies that were in place during the public health emergency that ended in May, which means that far fewer people are on Medicaid. Medicaid's the biggest payer for behavioral health. There is a nationwide shortage of people in the workforce. We'll talk a little bit about that. There's also some opportunities with digital mental health, which is becoming really prevalent as a new way of getting treatment and new way of even getting diagnosed. And it's still early. I like to say we're at the end of the act one of a five-act play, but I want to unpack that a little bit. The federal government's getting involved in a new way, and of course, AI is what everybody's thinking about, although it's too early to know how much that will solve the crisis by itself. So, what I'd like to do is kind of take you through really these three pieces, and we'll do that in the next 20 minutes if we can. But I want to talk about what is the problem, a little bit about how we got into this, and most of all, if you've read the book, you know I'm super hopeful. So let's focus on solutions as well and how we're going to get out of this. So let's jump in. The crisis to me is really defined by what we call the public health measures of morbidity and mortality, or just disability and death. And those the stories aren't great. If you look at disability, neuropsychiatric disorders are way at the top of all medical sources of disability, and a lot of that has to do with the fact that they start at an early age. And so if you get sick at age 15, 18, 22, uh, the impact can be seen throughout the lifespan. So you get lots of disability over the course of a lifespan. These are the chronic disorders of young people. And if you've had people in your family affected, you know that it really takes them out of the workforce. It may take them out of school. It really does have long-term impacts. And also so much of what we think about as disability or morbidity. So unemployment, homelessness, incarceration, these are really prevalent and a huge part of a particularly serious mental illness. Mortality is the other part of this. And if we just look at mortality from medical causes, it's mostly a good story. We've reduced the mortality from stroke and heart disease and AIDS and leukemia in kids by more than 50%. But when you look at suicide, the rate's gone up about 30% since the turn of the century. And that's really a little bit unusual. Most developed nations have seen a decrease of 10 to 20 or even 30%. The US, the rate has continued to climb. These days, we tend to talk about not suicide alone, but suicide and drug overdoses and even alcohol related deaths as so called deaths of despair. This book, this is actually a book cover. It's very uh, scary looking, but it's is this kind of a scary story by Anne Case and her husband Angus Deaton. They received the Nobel Prize for this work a few years ago, and it's a way of rethinking the mortality associated with behavioral illness. And I think for NAMI, it's probably a better framing than just talking about suicide because often we're not clear whether a drug overdose is a suicide or whether it's an accident. And same thing with some alcohol related deaths. But the main point here is that if you start to to bundle these together, the numbers are staggering. That's what a three or fourfold increase since the turn of the century. And in certain areas, like when you look at suicide in kids, the rate is up 60% just since that 2001. So these are really worrisome numbers, um, enough so that it has changed life expectancy in quite a striking way. You don't see this in other developed countries. This was actually data just from last week that Case and Deaton published. But it's really interesting, and how much of this is driven not only by mental illness, but by other factors. So when you look at where that mortality gap is greatest, it's often between kids who have a college degree and those who don't. And there's a lot more we can say about that. Not all of that has to do with mental illness, but mental illness is often a big piece of it. Yes. Hey, one last thing about this, because I want to move on, but coming out of COVID or almost out of COVID, I have to confess there are more people with COVID now than I can remember at any time since 2020. But it's a time when we can look back a little bit, and certainly the mortality was astounding. 1.1 million people lost their lives to COVID, but those are mostly people over 55 or over 65. When you look at, we were talking about mental illness as the disorders of young people. When you look at COVID in people under 30, there are about 8,268 deaths in the course of the pandemic. Same period of time, 30,000, 31,000 suicides. Actually, this is just in 2020 and 2021, 62,000 overdose deaths in this age group, in the same age group. We think that there were probably 140, 150,000 deaths of despair in kids, and or these people under the age of 30. So really striking how this is during the pandemic. When you look at young people, it's not really the virus as much as the deaths of despair that explain so much of the increase in mortality. Just really quickly, we're spending a lot more than we were even before the pandemic. You can see the investments in mental health care had gone way up. But I think it's important for you to know, and for NAMI in general, when you advocate and when you think about mental health as a social problem and as an economic problem, and I do think you need to make an economic case in your advocacy. You want to remember that the real costs of mental illnesses are not the care. It's actually in not getting care. That's where the biggest cost drivers are. I'll give you one example of that. Um, when you look at the highest cost patients in the healthcare system, this is looking at total cost of care, both medical, surgical, and behavioral. Um, 75% of those highest cost members in any healthcare system have a behavioral health condition. About 40% of them have serious mental illness. You can see that here. But most of them are not getting behavioral health care. And the real driver, even if you look at this 40% over here and you say, what's costing so much? And we're talking about 40, 50, $60,000 a year per patient. Most of those costs are on the physical health side. And these are people who probably are not getting any behavioral health care. So we have to remember that there's a case to be made here for providing behavioral health care to offset the massive medical, surgical, physical health costs for this group. So real quick, how do we get into this mess? And why is this costing so much with such terrible outcomes? And the answer is mostly that unlike COVID, where we had something new happen, this is really our failure to provide care to people who have illnesses that have been around for decades and probably centuries and even millennia. Um, what I mean by that is that it's actually a true care crisis, and it's not one thing. From my research when I was doing the book, what I heard most about was that we just don't have the capacity. We don't have the beds. We don't have the people. We don't have the safety net we used to have. it's really surprising that unlike cancer or heart disease or diabetes, many of the people who should be in care are not. And oddly enough, the sicker you are with a behavioral health condition, the less likely you are to get care, which is really different from medical surgical needs. When you do get care, the quality ain't great. It's, I'm sure it's no different in New Mexico than it is in the rest of the country, but there's a real delay. They're just, it's very hard to get in to see somebody. Much of the care goes through an emergency room. It's very fragmented, so there's no integration with primary care or physical health, and it's generally done under crisis conditions. It's not proactive. Uh, I think there's a huge problem that the field hasn't really been accountable. We haven't looked at outcomes and held people to outcomes and incentivized outcomes. And finally, there's an equity problem here, which I want to talk about. It's probably not equity in the way that you may think about it, but I think there's a really important issue, particularly for the people with serious mental illness and the way that we have viewed the problem. Um, Give me a minute and we'll just unpack each of these. And I'm going to give you kind of an image to think about. We'll start with capacity because that's one that is maybe the most graphic. If you just, we can talk about workforce, we can talk about safety net, but if you just for a moment look at beds, people with mental illnesses often end up needing to be institutionalized for their own safety or for the safety of their families. And we don't have the beds in the public system. We did when I started my career 50 years ago. We had plenty of beds in state hospitals, but those were all closed in the 70s and 80s. And as you can see from the blue line here, there's about a 95% reduction in the number of beds. We have about 34,000 beds in public institutions in the United States. We have some private beds, but those depend on having insurance. At the same time, we've replaced that with a criminal justice solution. So we've put people into jails and prisons, and you all know that jails and prisons are kind of the de facto mental health care system for much of America. But this graph is interesting because it says that on any given night, there are probably 10 times as many people. Well, this graph doesn't say it, but take my word for it. There are probably about 350,000 people with serious mental illness in a jail or prison cell, and only about 34,000 in a hospital. That's kind of extraordinary that we have, in a sense, criminalized the problem of people with mental illness, so they don't get treatment until they end up in a criminal institution, unbelievably. I mentioned engagement, and this is what I mean by that. If you look at the 14 million or so people with serious mental illness, about 40% get services. 40% of those would get what the scientists call evidence-based or minimally acceptable care. And of those, about a third get well, a third somewhat better, and a third don't benefit at all. I call this the 40-40-33 rule. And it's a reason why we haven't made more progress because the fact is we can improve access, we can improve care, but if 60% of people are never coming in, it's going to be really hard to reduce death and disability. You're just never seeing them. And this is an important issue for us as we try to solve the crisis, is to think about the problem as being more than just more clinics and more doctors. We need more engagement, and that requires a very different approach. More about that in a few minutes. Quality, just really quickly, we'll just look at the blue line. In the United States, we have something called HEDIS. Oh gosh, it's health. What does that stand for? I can't remember, but it's a way of measuring quality across all of medicine, and hospitals and clinics get scored for this, and it's really striking because it sets out very specific targets you have to hit. This blue line is the likelihood of being followed up within 7 days, the follow-up 7 after being discharged from an inpatient mental health service. So we know that first week is kind of the valley of death for a lot of people when they come out of the hospital and they are back to where to facing all the things they had to deal with before they went in. It's a critical time for people to be seen as outpatients, and yet less than 50% of people in the United States are seen at all during that period of time. I mentioned before the lack of measurement is a huge problem. Less than 20% of practitioners have any kind of measurement. Uh, you'll hear about this, and you might have heard about it from Ken Duckworth. The need for measurement-based care is really important to improve quality. If you don't measure, you don't improve quality, and that has been an ongoing problem. And then finally, this is the last and maybe the most painful slide before we talk about solutions. This idea that we have a severe equity problem. For the book, I sort of reframed the issue of serious mental illness to think of this as kind of as if the people, these 14 million people, were a marginalized population or like a racial ethnic group. We talk so much about diversity and equity and inclusion, and we're talking about the needs of Black and brown people, and these are those blue bars here. But what's so striking is if you think about serious mental illness um, in terms of life expectancy, employment, the relative risk of use of force by police, or the likelihood of incarceration, uh, this group looks worse off than any of our racial or ethnic groups. It may be, I didn't, for this graph, I didn't include um, Native Americans, which uh, probably are worse off than Black and Latinx groups. But and nevertheless, my point being that we've got a group of people that effectively are untouchables. They're like our lowest caste, and we don't talk about it. In a sense, we're kind of in this Jim Crow moment for mental health, where we have now millions of people who are homeless, who are incarcerated, who are really our most marginalized population, and they're so marginalized we don't even want to address it. That's a problem, and that's part of why I think we need to be really serious about the solutions. So that's where I want to go. Take another 10 minutes maybe to unpack these and give you a sense of what's possible here. I'm actually, as I said at the beginning, really hopeful. I think there's a lot we can do. Um, for NAMI, it's really important to remember um, that the changes don't necessarily require a lot of money or a lot of sophistication in terms of high intensity care, like you would expect for neurosurgery or for even orthopedics. Here, we know that we have really effective providers in peers. So the peer-to-peer movement, which NAMI's been a huge champion of, is so incredibly significant and one of the ways in which we can actually change outcomes. I'd say the same thing about family to family, which NAMI has championed. Um, I'm very involved with the Clubhouse movement, and I've been more and more impressed by the impact you can have with interventions that are really not medical. They don't require clinics, they don't require uh, any high tech intervention, but simply giving people a place to go every day where they have a peer group, a social support group, and they can get help in finding housing and finding jobs. Um, and then an important piece to remember, which I think we don't think enough about, is that even some of the people who one finds on the street with the most disabling picture of being homeless and maybe drug addicted and um, psychotic, they can recover. And it's probably, I mean, if you hear nothing else from me today, it's so important to you for you to know that we have effective treatments. If we give them early and we give them in the right dose in the right way, we have a lot we can offer, and there isn't really any reason why the vast majority of people with mental illness can't fully recover and become actually part of the solution. They can become peers who help others along the way. Um, the other point to make is in terms of solutions that technology really is making a difference. This is a field that's largely moving to remote care with telehealth, but it's still very early. And I think we have now the tools to be able to capture a lot of additional data and to get objective measures of mood and anxiety and coherence and psychosis by using um, AI to really decode speech and voice and face, using wearable data to know about sleep, um, and even kind of closing the loop using a scribe that collects all of the interview and provides very rapid summaries, very accurate summaries, and then sometimes even can provide um, responses if it's prompted in the right way. So those kinds of interventions really do matter. And if you begin to take that innovation mindset to the set of problems that I just laid out for you, um, I just want you to hear that on every one of them, there's a lot we can do. I think when you want to build capacity, it means you do have to spend money and rebuild what was there before. We're doing that. The same with engagement, quality, accountability. There's a huge opportunity to use technology to solve each of these problems, not completely, but to at least make a big difference. And the same with equity, where we have an approach that I think really will matter. Uh, Again, let's just take a couple of minutes and I'll unpack these so you can get a picture of what I mean. On investment, ridiculous amount of investment in digital health generally, but in particular in mental health. This is venture capital investment, which was basically non-existent a decade ago, and is just as you can see here for mental health alone has been $12 billion in the last 5 years, which is just was unimaginable a decade ago. Some of the biggest mental health providers in the United States are companies that didn't exist in 2017. So we have a very different ecosystem for mental health service delivery. It's also true that we're seeing huge federal investment, and I don't want to take a lot of time to take you through the history. I do that in the book just to explain how mental health care has been the hot potato of a health policy. Nobody wants to pay for it, and it's just passed from states to the federal government, back to states, the states passed to the counties. But we're in a different world now where the federal government is leaning in a way we haven't seen since the 1960s. I worry a little bit with when the federal government becomes a healthcare system, but in this case, I'm pretty excited. It's an acronym, and I hate to sort of lay this on you, but you should know about it. The this project called the CCBHC, the Certified Community Behavioral Health Clinics, which started about 5 years ago as pilot projects. There wasn't New Mexico wasn't part of it, but it is now because this program, which kind of bumped along in 8 states in 2017, 18, and 19, got new life last year with the Congress committing $8.5 billion to essentially build a new nationwide federal mental health program for people with serious mental illness and substance use disorder, adults and kids, whole person care available no matter what your geography, no matter what your background, no matter what's your age. Pretty extraordinary, and I think it's a moment. And now this is just rolling out. New Mexico, I think, has a few clinics, but this will be a huge new era for mental health care in America. And most interesting is that these CCBHCs are paid for with a not by grants and not by demonstration project money, but they are becoming entitlements where you'll get a pot of money for a population and you can decide how you want to use it to be able to provide the best care. I think in terms of time, because I want to make sure we have plenty of time for conversation, I'm just going to take you through the rest of this pretty quickly, but I want to make a couple of points. For engagement, quality, and accountability, there's a tremendous amount we can do, and you can just see it here on this one slide. On engagement, I think the development of apps and a variety of mobile interventions for remote care has been astonishing. It's really democratized care already, and the ability to be able to provide psychotherapy, coaching, peer support, and even crisis services on demand, and irrespective of your location, is pretty exciting. The same kinds of tools are increasingly helpful for integrating care, making sure that your primary care center knows what's going on in the behavioral health world. It's not done yet, but this opportunity to coordinate care by using technology, using new ways of capturing data and making sure that people are meeting certain quality standards. Which, as I said before, this has been a data-free zone without measurement. That's going away with the new tools, and even tools that can be used at the individual level. We sometimes call this digital phenotyping. It's kind of a funky word, but the idea here is that we can start to capture all the things that your phone already knows about you, how much you're sleeping, when you're becoming manic, when you're becoming depressed, are you becoming socially isolated? All of that information is already present on your phone, and the ability to begin to use that to help manage care is exciting. The idea being that by putting all that together, we create a learning engine, a kind of learning healthcare system, which we already have to some extent in the care of diabetes, but we haven't really done that in behavioral health. And I'm pretty hopeful that we can go there. I want to finish up by talking about this last piece, which is the equity piece and how we do that. I spent a lot of time working on the book, just traveling the country, and I spent a year as the mental health czar of California, which was kind of nice because it gave me a ticket to go places I wouldn't have gone otherwise. Spent some time on Skid Row in Los Angeles and met a wonderful street psychiatrist there who was taking care of a lot of people with psychotic illnesses under these conditions. And when I asked him what we should be doing and how do we, that question I kept coming up with, which is how have we failed? Why have we not done better? His answer was that we have the wrong target. We're trying to treat everybody's illness the way as if it's a medical illness. And the medical model isn't really working for us. We need a recovery model. And when I asked him what that meant, he said, it's just the three P's. And by that, he meant people, place, and purpose. It's social support. It's having a place to go that's safe and supportive, and it's having a purpose, say, having a mission, having some reason to recover. We aren't doing that in healthcare. We aren't providing that, but we could. And his point was that if we want to actually reduce death and disability, we've got to start changing healthcare to provide the three P's. The crazy thing about this is we know entirely how to do this. Like this is very old school. This is what we were doing in the 1980s. We had ACT teams, we had supportive housing, we have supportive employment. We had all this stuff. The clubhouse is a really interesting place where people can spend the day, get peer support, get help with jobs, get help with, as I mentioned before, get help actually even with work. All of this is part of what the game plan looks like to help people recover. The problem is we don't pay for it. There's only one piece of this that gets paid for, which is the medication and some therapy, often post hospitalization. There's some states that pay for ACT teams, and sometimes there's some support for housing and employment. It's very limited. I started this company, Vana Health, to really fix that fourth P, the payment problem, and to figure out a way that we can begin to shift the dollars so that we're providing all of this psychosocial rehabilitative care to make sure that people can recover. So I'll finish up by just saying that I think that this isn't to do away with the medical model. We need medication, and we need the same kind of rigor and reimbursement and research that you have for any medical problem. But the solutions are more than medical. They have to be social, environmental, and even political. The point here is that we want to go beyond just symptom relief. We really do have to think about helping people to thrive. I'm not sure you have to do that in infectious disease, and I'm not sure you have to do that even in the treatment of asthma. But here, you actually have to I think, ultimately redefine care in a way that's different than what we do for so many parts of the healthcare system. And we can do that. We're doing it in California, where under Medicaid, a provider can write a prescription for food or housing. The three Ps have been adopted for those CCBHCs and for Medicaid providers in a couple of states. So there's a real opportunity to change all of this. Um, each of these parts of this crisis, when you look at it through the lens of recovery, there's a lot that can be provided, a lot that can be done. The trick is going to be figuring out a way to pay for it, because in healthcare or in services here, if it isn't paid for, it doesn't get done. And so we have to come up with the data and the economic arguments to clarify that this is doable. And by the way, it actually, if you do it right, will save money. So I'll finish by just saying we've got a crisis, we've got solutions. We need this recovery model if we really want to bend the curve. And to me, it's just a helpful formulation to say that yes, medications are important. The medical part of this is essential. But if we really want to fix it, we've got to think much more broadly than a typical medical model would do. So I'll stop there. Thanks so much. And again, book is healing. The company is Vana. The Steinberg Institute is the team that's done so much of this work in California. But I'd love to get your thoughts and reactions, and hopefully we have a little bit of time that we can
We do.
talk about any of this.
Great. Thank you so much, Dr. Insel. That was a really, really nice overview of your book. I'm so glad that you made a point of mentioning the three Ps of recovery: people, place, and purpose. For my own situation, I shared with you that I'm a 25-year survivor of periodic bouts of depression. And I had the people part, the connections with friends and family, down pretty good. The place, as far as my housing and things like that, I was in a good situation. But when things got really bad for me 14 years ago, I was struggling with purpose, and it was coming up with a purpose that really made a difference for me in my recovery while I was at an inpatient program for 30 days. So the whole people, place, and purpose really resonated with me. So attendees, if you'd like to ask a question verbally, go down to reactions at the bottom and hit raise hand, and your little yellow hand will pop up, and either Jessica or I will call on you and we'll unmute you. Dr. Insel, we've got a couple questions in the chat. Also, anyone else, feel free to put your question in the chat. Dr. Insel, Helen asks, I feel that the insurance companies rule the quality of care. How will U.S. mental health care get better if the insurance companies have all the power?
Yeah, that's really the issue, right? And that's my point, is that they do rule. Of course, in behavioral health, it's more public insurance, Medicaid, Medicare, than commercial insurance. It's different from the rest of healthcare, where the dominant payer is the commercial side. So we have to deal with both. And the case, I mean, if you want to fix this, you're going to have to convince payers that they're actually spending too much money in all the wrong places. That's why I made that pitch for, when you look at total cost of care, it's really striking that the failure to provide behavioral health care to people who need it is what's driving the highest cost on the medical side. It's mostly pulmonary, some diabetes, some cardiovascular. But the case you have to make is to them, and it's a business case, is that providing behavioral health care brings down your overall costs. You're going to have to spend a little bit more on the behavioral health side, though it's nothing like a neurosurgical procedure, and it's not like any of the new $10,000 a pill cancer treatments. So yeah, you have to maybe write a prescription for an SSRI, which costs about 10 cents a pill. Or maybe you have to provide psychotherapy, which can now be done very economically well. But if you do that, you will actually reduce your overall costs. And I don't think we've done an effective job of providing that business case, but that's what we're trying to do at Vana, working initially in Philadelphia with the most expensive patients, saying, look, if these patients are costing you on average $35,000 or $40,000 a year, and for $20,000 a year, we can get much better outcomes because we're giving them a clubhouse to go to every day, and we're giving them housing, we're giving them all the things that the healthcare system hasn't bothered to look at.
Could I
Thank
make
you.
a quick comment to follow up on that?
Of course, go for it, Terry.
Yeah, on the insurance piece, I'm going to try not to get my Irish up too much, but here in New Mexico, most behavioral health providers don't even take insurance.
Yeah, that's true. Nationwide.
And it's because the nightmare that the insurance industry provides to those providers. And I have another question on another matter. I don't want to jump on anybody else, but when you talk about the quality of care, my family has, not only my immediate family, but my extended family has incidents of psychotic illness. And we found that in terms of quality of care, very few providers will even address it. And if they say they treat it, they are arguably ill-equipped. And in my work in NAMI for more than a decade, it seems like increasingly I run into individuals and family members that are being diagnosed with some type of psychotic illness. What would you say to that particular issue?
Let me make sure I understand the issue. So you're talking, Terry, about people who have a psychotic illness that's not been diagnosed?
No, it's been diagnosed as such, but there are providers that say I don't treat psychotic illness. Or
Right.
if they do accept a patient with some psychotic illness diagnosis, along the whole spectrum, I won't outline all the diagnoses, you know to them better than I, they are not equipped to handle it. And
Yeah.
I can give you just a specific example. One of my sons that brought me into NAMI that has a psychotic illness is, as the members of Santa Fe NAMI know, because he's been a part of our organization for some time, he's very bright and he's very articulate and he's able to communicate. And he's been told by providers and local hospitals, you can't be schizophrenic, you're not talking back to the television. So their view of psychotic illness is incredibly narrowly defined, and they're not able to meet him where he is.
Are they specialists or are these primary care or ER docs?
Specialists. These are
Yeah.
specialists, behavioral health providers, and even psychiatrists and counselors. Same thing.
Yeah, it's kind of amazing, isn't it? I mean, it's kind of hard to believe that you'd face this in cardiovascular care or cancer care. And I mean, on both of your points, both the lack of being able to find any provider and then finding a provider who's not very good. One of the issues that this spills into is what is the general parity conversation. And parity, for I think you probably all know what that is, but it's simply the expectation that in the insurance world that the insurance has to cover mental health at the same level that it covers physical health. You can't have different copays. You can't have different levels of within network providers. You have to have basic fairness here, and you have to be on the same. You have to be at par or with parity. And the parity law was passed in 2008, and it simply has not been enforced anywhere.
Implemented, right.
So the White House just had a session 2 weeks ago in which the president said, enough already, we are going to, and he brought Department of Labor, Department of Justice together with him, so secretaries from both departments saying, it's a new day. We're going to hold insurance companies' feet to the fire, and we are going to enforce the parity law, and these are the consequences for companies that don't abide. The problem here is that if you're an insurance company, you may not be able to find the people to come within network we simply don't have the workforce that we need. And it's not just psychiatrists, it's nurses, it's
Right.
psychiatric social workers, a whole bunch of people.
Right.
So it is a bit of a challenge. It would be easier if they paid well, if they paid as much as people are making in private practice. Then, in fact, some people might be willing to do this in a healthcare system. But right now, mental health, particularly psychiatry, and particularly child psychiatry, is is almost unique in the fact that so many providers do not accept any insurance, public or private. The only other specialty that's even close is dermatology, and that's because there's this whole cosmetic industry for people. But in psychiatry, particularly in child psychiatry, it's kind of stunning. You'll find very few people accepting insurance. By contrast, in pediatrics, it's very hard to find a pediatrician who does not accept insurance, public or private. So we've got to start to blow the whistle on that. And this is where NAMI can really be helpful. I think we have got to figure out a way that we hold insurance companies to the standards that allow them to bring people in by paying enough. And we've got to change the expectations and make it clear that providers need to start seeing people with insurance or using their insurance.
Thank you for that, Dr. Insel. We'll move on to a question from Jonathan, if I can get him unmuted. Jonathan, you have a question?
Yeah, Dr. Insel, thank you so much. Just a brief introduction. I'm a retired family physician from Kaiser, Colorado, moved to New Mexico about a year and a half ago. While I was in Colorado, I served on the board of directors for Mental Health Colorado and on their policy committee, and also served on the board of directors for a community mental health center. So everything you're talking about is so spot on, and it's good to hear it being reinforced. And right now with NAMI, we're actually having a large and pretty vociferous conversation about how do we address the mental health issues with our kids, the kids in schools, the youth. And we're talking about how do they get the care they need? And then how do we even find out about their mental health issues and the value of screening? And just a comment before you answer, we go into that, is that I have seen many times these metrics, these quality metrics, they're often more involved process and less about the outcome of the individual patient. And that has always bothered me, because it's always, it's always good to say you got in 3 days, you got to see somebody, they're on their medicines, they're on it for 6 months, but how are they doing? We don't really know sometimes, but
Yeah.
we pat ourselves on the back, Thomas, and say that they've done great, because we did great. And that's not true.
Yeah, it's a great point. And I usually have these 4 categories of inputs, outputs, outcomes, and impact. And what we do in healthcare is largely we try to increase the inputs and then we measure the outputs. So put in more money and we hope there are more visits. We don't know if that is improved outcomes or not. And we don't ever look at population-based impact. And all of that is really where we need to be, and actually is what we need to pay for. So this will start to make more sense when we tie the incentives to outcomes and impacts rather than just more visits. But to your question, Jonathan, about youth mental health, I'm not sure I have the full answer to that. I'll tell you what we're doing in California, because it's ridiculously ambitious, and I don't know if it'll work, but we have a governor here who just became obsessed with this problem, and he had a big surplus in 2021 that we weren't expecting. And pretty quickly he put together this kind of unique youth mental health initiative with $4.7 billion invested to kind of rebuild. I mean, just to say, whatever we've been doing doesn't work. We got to start over. And so the first thing he said was, we're going to make our schools the center of gravity for mental health care. It's not our clinics, it's not our pediatricians, it's not the hospitals. We're going to need those. And he put money into building hospitals and beds. But he said, schools is going to be where we do this, but we can't ask teachers, we can't ask guidance counselors or administrators in schools to do anything more. So we're going to create an entirely new workforce, 10,000 people staffing 10,000 schools. And that workforce will come from our community colleges. So it has the diversity and the geography and all that, because it's a very complicated state. And we're going to train up people with a set of skills. So at least they'll be able to screen and to know which kids are at risk. And they in turn relate to a sort of virtual platform that we put in place. So kids and families can get care on demand when they need it. And that in turn links to both pediatricians and by telehealth to child psychiatrists who are based in a few of the cities in California. It's a much more complicated plan. There's a lot of other pieces to it, but it does take that kind of an approach, this kind of new strategy. I was visiting with some folks the other day. They were telling me about Safe UT. It's in Utah. Every kid, every middle school kid, I think it is, or high school kid in Utah has an app on their phone to help them manage their mental health and to teach them resilience skills and mindfulness skills and all of that. And it also is a way that they can get care again on demand. 880,000 kids have this. They've reduced their suicide rate by 347 amongst kids in Utah alone. Utah had one of the highest suicide rates for youth. And so it's hard to know whether this program is the answer, is the reason why there are fewer suicides, but there were about 8,000 kids for whom there was an intervention last year. So and they're tracking it very, very carefully. So I think there are solutions. The last one I'll mention, which I think is super interesting, but a little hard to navigate, is everybody's been pointing their fingers at social media. And I got to say, I'm one of those people who, blames social media for a lot of the ills in America, but particularly for kids and kids' mental health. But there's an increasing interest in taking social media and making it the solution, not just the problem. So somebody sent me this last week that on, what is it? Not on Roblox, on Minecraft, there's a whole new, I think it's called Minecraft Experience. I don't know enough about it, but it's an experience just for kids who have lost a parent. So kids in grief. We're trying to do that with Roblox and trying to do that with Fortnite, and Discord is the social media platform for all of those. That's where kids are. So instead of hoping that kids will call us and come to the clinic, meeting them where they are because we know when they're struggling, they tell us in so many ways on those platforms. And so having something available in the moment, and not just a pop-up that says, call 988, because they never do. For one thing, they never call anybody. They use their phones to text. They never use their phones to call.
Right.
So you could say, text the crisis text line, and they do sometimes. But better yet is to actually give them something in the moment that can be helpful. So there's a lot going on as people try to address this. And it's probably, again, not going to be a single fix, but it's a really complicated, interesting problem for which I do think we have lots of opportunities to address it. And some of it is at the kind of screening end, and some of it is at what do you do for kids in early psychosis, and using something like coordinated specialty care to make sure, as our governor likes to say, in California, no child that has a first episode of psychosis will ever have a second episode. So if you've gotten that point where you have a psychotic episode, we are going to do everything to ensure that you have the rehabilitative services for 2 years that ensure that you totally recover, you get a job, you finish school, you do whatever it takes to make sure that you're on the path. So we can do this. Again, we know a lot that works. We just aren't doing it in a way that's coordinated and paid for.
Well
we've
said. Thank you.
can I just add to that really quickly?
Yeah,
I
really
apologize.
quickly, please.
And we've talked about screening, and I'm a huge proponent of screening. But what terrifies me or worries me about screening, Thomas, is that if you don't have the resources to answer what you've got in your screening, you may have done more harm than good.
Yeah, absolutely. But that's why you have to build a workforce, and that's what we're doing here.
Thank you. We're just about out of time. We still have another question in the chat from Faith. And Faith asks, I'm curious about ideas to deal with medical doctors in the ER being the gatekeepers to mental health assessment and care.
Yeah, it's a great question. It's a mess, right? I mean, we have ER boarding everywhere in America right now, and it's partly because there is no place for people to go. We're asking ER docs to make tough decisions. This is not an area that they're all that comfortable with. Back to, to Terry's point, they often don't even know what they're looking at. They don't have the training, and many of them simply aren't interested, even though, unfortunately, emergency rooms like jails have become kind of the first point of contact. There are solutions. So there are increasingly, particularly in Arizona and Colorado, there are these psych emergency rooms that are set up, sometimes as adjunct to a medical surgical ER, but they're 24-hour places with Barca loungers kind of, and very talented, skilled staff. The best examples are in Tucson and Phoenix right now, and those in turn can spill over into 7-day acute care places. So again, this is building capacity. A bunch of hospitals are putting these kind of like a psych ER as an adjunct to their medical surg ER. So they just are building on an additional space for this. The hard part is getting the psych expertise 24/7 when you need it, and that's where sometimes having telehealth can help. But
we have one of those, Dr. Insel. We have one in
Okay.
here in Santa Fe, behavioral
great.
observation unit as part of the emergency department with our local hospital.
That's great. But the whole point is you can get the assessment there, but people need to go elsewhere for treatment, and
Right.
we
do
simply have to build that out. Okay.
I'm sorry, Betty, to interrupt, but I
ahead,
actually
Nicole.
asked that question, and somehow Faith and I were the same person because we work for the same department. But we do have a wonderful behavioral observation unit, and we use that a lot. But the problem is they still need to be screened by a medical doctor to get into it, which I understand for safety. But we end up losing people there who say, I don't want to be here. I'm fine. So I know that this is a complicated question, and I think that we really need to build out those psych ERs, and that's exactly what I would love to see Santa Fe do fully. And we just miss people in those cracks. That's where we miss them.
It's so hard, right? Because these are often people not looking for help. They're trying to avoid it. And we're talking about illnesses that affect your judgment. And so at some point you have to start talking about involuntary treatment, which nobody likes to talk about. But there's no path to recovery without it. There are times when people need to be treated even when they don't want to.
Right.
Thank you. We have time for one more quick question and answer. If anybody has a question they'd like to ask of Dr. Insel. Seeing none, we're going to go ahead and wrap it up. Yeah, Dr. Insel, on behalf of NAMI Santa Fe, thank you so much for presenting to us tonight. Thank you for the incredible book you wrote last year, and just for your life's work in this extremely important area.